Hello again, future nurses. It is Julie here. I'm going to do a quick review of Unit 9. There is quite a bit in Unit 9. I'm going to start this half just with schizophrenia. I will pause and do a separate video for our personality disorders. So we're going to go over what are our psychotic disorders, and we're going to go over antipsychotic medications. So if it does look like I'm kind of going back and forth or pausing at some point in time, it might just be as we switch from the disorders to our medications. So we do have a few different types of psychotic disorders. Generally, we think of schizophrenia. It is our big one. It affects only 1% of adults. It is characterized by psychosis, which is a alteration in reality. You can't tell what is real or not real. Most of the time, this develops in late adolescence to young adulthood, especially in males the age of 15 to 25. Childhood onset before 15 or late onset, those above 40, can happen, but it is very rare. Those who develop it older tend to have like a better course, more mild symptoms. All of these patients are going to have at least one psychotic symptom. And we're going to go through and kind of talk about what those are. Females are the ones who tend to develop it late, but honestly, if you can make it to the age of like 35 without schizophrenia, you have pretty much, you are not going to develop it, or it will be extremely rare. So what we see in these patients, and we're going to go over what all of these are. They have, for a significant portion of a month, at least delusions, hallucinations, disorganized speech, gross disorganization or catatonia, a negative system, like I said, we will talk about what these are, or functional impairment. But it continues for at least 6 months. So you have the psychotic symptom, which are a lot of these first ones, or you have these negative symptoms, which we'll go into. And honestly, the disturbance lasts at least a month. 6 months total. So childhood onset, 1 in 40,000. So not common. We tend to see it in those 18 to 14. College students is a big one. It affects all races, all ethnicities equally. We do see it more in males. We do see it more in urban areas. We do have a bunch of different comorbidities. Substance use is particularly alcohol, marijuana, but that's a big one. Nicotine dependence is huge. Anxiety, depression, suicide, violence are all different things we think about it. I'm trying to think if there's anything else. We do see a lot more physical illnesses. The risk of premature death is greater. I think your book talks like 4.5 times greater. However, generally what we see is that those with schizophrenia die 20 years sooner. So if life expectancy is 80, these individuals only have a life expectancy of 60. Polydipsia is common, compulsive drinking of fluids. It occurs in about 20% of those who have schizophrenia, and they wind up with hyponatremia. When we look at biological factors, this is a genetic disease. We do see a huge risk of inheritance. We do always have to find out if this is the first time. So if we have a patient and they're first presenting with these psychotic symptoms, we need to figure out like, hey, has this ever happened before? And then we also need to figure out, do you have a family history of schizophrenia? Because if they have a family history of schizophrenia, it is most likely schizophrenia. We do have other things that can cause psychosis, which is why that's a good question to ask. But 80% of the risk of schizophrenia comes from genetics. Toxins, trauma, all that other stuff affects the genes. Dopamine theory. If we look at neurobiology, our first antipsychotic drugs affected dopamine. So we do see dopamine come into play. We do see some schizophrenia, glutamate, GABA also come into play. We do see difference in how our brain is structured, how it's developed. And we do see differences in brain imaging in these patients. If we look at psychological and environmental factors, when we look at prenatal stresses, if the mother has the flu while she is pregnant, especially in the second trimester, honestly, any type of infection, it increases the risk that child will have schizophrenia. If the father is older than 35 at the child's conception, All of those things do come into play. Stress increases cortisone. Cortisone affects the hypothalamus. So those who have a lot of stressors are more predisposed. Childhood sexual abuse, chronic poverty, growing up in a foreign culture, trauma, all sorts of those things come into play. Like we said, living in an urban area, high crime environments also increases the risk. And we look a lot at like things in dry cleaning, pipe cleaning, pipe waters, what's found in the water. Prognostic considerations. That means how well is a patient likely to get better? We do have many individuals with schizophrenia who do not fully respond to treatment. There's usually some type of mild to severe, so a huge range of residual symptoms that causes long-term dysfunction and disability. So this is not something you can always just get over. A delusional disorder. So a delusion is more of like a thought. The CIA is following me. I really invented Tesla, and Elon Musk has copied me, and he has stolen all of my money. We have this belief, grandiose, I have millions of dollars. Persecutory, someone is out to get me. Somatic has to do with kind of our body parts. My arm is not my arm. Referential means that ordinary events have hidden meaning. So the music on the radio is being played for me. Delusional disorder has just the delusion, no hallucinations, only a delusion, which is why we call it delusional disorder. And it does not normally impact functioning. You go about your life. Brief psychotic disorder is a timeline. We have psychosis, delusions, hallucinations, strange speech, strange behaviors, but the symptoms last less than a month, and then the patient goes back to normal. Could they later carry on and this comes back something? Absolutely. However, to be diagnosed with a brief psychotic disorder, we see the psychotic symptoms and then they disappear. Schizophreniform disorder is very much like schizophrenia, but to be diagnosed with schizophrenia, you have to have symptoms for 6 months. Schizophreniform is less than 6 months. We don't always know what the prognosis is. Some people go back to their original way of functioning, and that's the end of it. Some people progress to full-blown schizophrenia. Schizoaffective disorder is basically a person who has schizophrenia and bipolar at the same time, or schizophrenia and major depressive disorder at the same time. So just like you can have a patient who has like COPD and pneumonia at the same time, it stings. They both affect their respiratory system. They're both going to affect how your patient is breathing. Schizoaffective is a patient who has schizophrenia and depression or bipolar at the same time. This is more so just a timeline. So a brief psychotic disorder is less than a month. Schizophreniform is 1 to 6 months. Greater than 6 months is schizophrenia. Differences between them, again, this is just a way to see it. A brief psychotic disorder, we are only having our psychotic symptoms for less than 30 days. Schizophrenia, and I don't like how they organize this, it does not work for my brain. Schizophrenia, you have your periods of psychosis. All these symptoms persist for 6 months. Schizoaffective, we have our schizophrenia diagnosis plus our bipolar and depression. Schizophreniform is our psychotic type symptoms for 1 to 6 months, and then we go back to normal. I know this does not make sense because we have not talked about what those negative symptoms mean yet. We will get there. So we do again have some phases of schizophrenia. We have some mild changes that start at first, and that's that prodromal. Has to do a lot with like your executive functioning. So we see someone who is pulling away. They're not necessarily going to work as much. Their school and job performance is kind of decreasing. We may be like, hey, they're just not doing right. But we don't see the psychosis or anything yet. So we're like, what's happening? The acute phase is when it exacerbates. Symptoms could be very disabling. We see the hallucinations, the delusions, all sorts of things come into play here. Our stabilization phase, the symptoms diminish. Our psychotic symptoms especially diminish. We are going backwards towards our previous level of functioning. And in that maintenance phase, we're still withdrawing from our society. We still don't quite know what's going on, but we kind of chill. If we look at this graphic, it's a little different. It has combined stabilization and maintenance into residual. But we go from this prodromal phase to the active phase to the residual back to the active, and we kind of circle between I'm psychotic, I'm not psychotic, I'm psychotic, I'm not psychotic. And remember, those psychotic symptoms are like our hallucinations, our delusions, our strange speech. So what are we looking for? We're going to look at things, 4 different types of symptoms: positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. We're going to go through some different slides. We're going to talk about what all these are, especially our positive symptoms and our negative symptoms. It's very good to be able to tell these apart. So in our positive symptoms, reality testing, what is real and what is not real? It refers to like our hallucinations, which I know it does not quite say hallucinations in here, but I promise you, positive symptoms I think of as psychotic symptoms. Positive symptoms are also sometimes thought of things that we don't see in a normal human. So positive is a plus sign. The normal person does not have delusions. They do not have hallucinations. So we do see those. We see alterations in speech, which we will talk about. We've talked about some of them already: word salad, echolalia, neologisms, concrete thinking, not being able to think abstractly. A good example of concrete thinking is actually with my little one with autism. The very first time I ever looked at him, I was like, he's jumping around, and I'm like, do you have ants in your pants? He freaked out and wanted to take his pants off because he truly thought when I said, you have ants in your pants, he really did have ants in his pants. He cannot think abstractly. We see that in a few different conditions, but we do see it in schizophrenia. So our alterations in speech. Alterations in speech are positive symptoms. Word salad. It's the most extreme. It's just a jumble of words. It is essentially if someone put words into a bowl and tossed them around like a salad and just started like pulling out and serving words to people. Throat hoarse, strength of policy, highlighters on a boat reigning supreme. You know what all those words I just said mean, but when I string them into a sentence like that, you're like, what are those? Clang associations. Everything rhymes. On the rack, have a Big Mac, or click, clack, clutch, close. I tend to think of it like Dr. Seuss. Clang is rhyming. Neologisms are just made up words. His mineralogies are poor, is the example Galen gave me in the notes. Sometimes I almost think of it like we've had patients who are like talking in tongues, and I'm like, what is it that you are saying? The patient knows what those words mean, but for those of us around him, those are not real words. Echolalia is the repetition of another people's words. So if I'm like, hey, Joe, time for your meds, Joe's going to respond, time for your meds, time for your meds, time for your meds. And they'll repeat it back. We do have some other ones, and we saw a lot of these when we looked at bipolar. So circumstantiality. We ask a question, they're going to give us tons of unnecessary details, but eventually read the point. Tangentiality, they're going to get off topic, they're going to go off on tangents, and they're never going to reach their point. Cognitive retardation. I know in kind of speech we don't use the word retardation. Retardation means to slow. So if we're looking at cognitive retardation, it's just slowing of thinking. There's going to be delays in responding to questions. They may not be able to finish their thoughts. Pressured speech we saw in bipolar in our mania patient. It's word vomiting. They cannot help. They have to get these words out. Flight of ideas is another one we've seen before. They're going to go from topic to topic to topic, and it's going to be so fast and so out there that you cannot follow. Symbolic speech, we're going to use symbols instead of specific communication. So if your patient is having sharp back pain, they might tell you that a demon is sticking needles in them to symbolize that pain, because they won't have any other way to express it. So we have a few other disorders or distortions in thought. Thought blocking is simple. It's a reduction or stoppage of thought. Oftentimes this is caused by hallucination. So your patient's talking, and then all of a sudden they get distracted by something they're seeing, and this starts thought. Thought insertion is especially uncomfortable because the person feels that someone else is putting the thoughts in my head. So we might have Mary who's sitting there and she's upset because she knows that Julie is putting the thoughts in her head. Thought deletion is the exact opposite. Someone is stealing my thoughts. My thoughts are now missing. Magical thinking is one we'll see a lot this week. My actions affect other people. So there's a great case study. It's in a different textbook than what you all have. And it is a guy with schizophrenia who was walking down the street, and he gets a phone call that his mom fell and she broke her back. He was so certain that she fell and broke his back because he stepped on a crack. And he went the next 6 months refusing to step on a crack because if he did, he would hurt his mother more. Paranoia, that irrational fear, mild, kind of guarded, to severe, someone's trying to kill me. Paranoia, especially in schizophrenia, does make our patient a little bit more dangerous. I'm going to skip through. So alterations in perceptions. These again are different types of positive symptoms, which we do see in hallucinations. So depersonalization and derealization are something you should be familiar with. We talked about these in dissociation. So depersonalization, feeling unreal, lost our identity, our body parts do not identify to us, they're not our body parts, out-of-body experiences. Derealization, our environment has changed, everything's kind of wavy. Hallucinations is the big one. We have a bunch of different types. If you have a sense, you can have a hallucination. So auditory makes up 75-80% of hallucinations. I can't remember exactly. There is no external stimulus. We are responding to internal stimuli with hallucinations. So auditory, we are hearing things that no one else is hearing. Visual, we are seeing things that no one else is seeing. Olfactory is smelling. Gustatory is taste. Tactile is feeling. Tactile, we tend to think like bugs crawling on us. Hallucinations is a priority because we have to find out if the hallucinations are command. It is a particularly disturbing symptom where the hallucinations are directing a person to take action. So a command auditory hallucination would be the voices telling them to kill someone, or to kill themselves, or some type of dangerous act. So we always have to make sure we're assessing our hallucinations to ensure they are or are not command hallucinations. Illusions are misperceptions. I grew up in the 80s and the 90s. Those optical illusions were huge back when I was a kid. And it's kind of the same thing. There is something there. There really is a power cord on the floor, but your patient is misrepresenting the stimuli and thinking that it is a snake. Alterations in behavior. Again, these are more positive symptoms. So catatonia could be an increase or decrease in movement. Motor retardation, again, retardation to slow. We are slowing our movements. Motor agitation. We are speeding up our movements, running, pacing. Oftentimes we're responding to that internal stimuli. Stereotyped or repetitive behaviors, there's no purpose for those. Waxy flexibility is usually seen in catatonia. And I know y'all are too young to know who Gumby is, but I always think of Gumby when I think of waxy flexibility. We could move the patient into a shape. We can twist them into a pretzel, and they would stay like that. They maintain an inappropriately given posture. Echopraxia is echoing movements. So echolalia is echoing sounds. Echopraxia is mimicking movements. We're echoing someone's movements. Negativism, we're resisting the requests of others. Impaired impulse control, we just cannot resist our impulses. Gesturing are unusual, illogical expressions, positions. Boundary impairment, I don't know where my body ends and another begins. So they might stand too close and not realize that it's not a good thing. Now, we're switching gears. We have negative symptoms. So positive symptoms are our psychotic symptoms. They think that we are adding to a normal human being that normally doesn't exist. Our negative symptoms are things we are taking away from a normal human. And they tend to all be A words. Anhedonia. I cannot experience pleasure in life. Nothing makes me happy. Avolition. Loss of goal-directed activities. I cannot begin or sustain any type of goal-directed behavior. And when we think about it, when we wake up in the middle of the night or in the morning, that is goal-directed behavior. Asociality. Decreased desire or uncomfortableness with social interactions. Affective blunting. Our affect, how our face is not making facial expressions. If y'all could even see me even recording this, like I'm talking with my hands and I'm showing y'all things. I know y'all can't see me because I don't have my camera on, but my affect is making expressions. If we look at it in schizophrenia, that affect is staying restricted. Apathy, things I used to do don't interest me anymore. I used to love playing the guitar, but now the guitar does not make me happy. Alogia. Reduction in speech. Sometimes it's called poverty of speech. When we look at our patient, all of those strange speech patterns are positive symptoms. But if I take away your ability to speak, it now becomes a negative symptom. So still looking at our negative symptoms, we do have some different affects. So that's outward expression. Flat, no facial expression. Constricted, we may be showing sadness, but nothing else. Inappropriate, it's not congruent with our emotional state. So we have a tragedy and someone's laughing. And a bizarre affect is just odd, it's illogical, it's inappropriate, all sorts of things. Now, I sometimes see, and this is kind of the difference between what we see in your textbook versus what we see sometimes elsewhere. I sometimes see that blunted or constricted affect as a negative symptom, but an inappropriate or bizarre as a positive symptom. If ever it's going to be something super confusing, we're like, wait, what? I will, of course, let you know. But just know it does vary. It's kind of like, does yogurt have tyramine? Textbook says no, or textbook said yes. Sonder said no or yes, whatever the opposite is. Okay, so our concrete symptoms. Concrete symptoms tend to think about, or cognitive. Cognitive symptoms tend to affect our frontal lobe, that executive functioning, how we process information, how we affect our memory. Concrete thinking, I gave that example before about ants in the pants. They cannot think abstractly. They interpret things literally. Impaired information processing, it's just slow understanding about what's going on. Executive functioning, setting priorities, comparing options, putting things in orders or groups, planning, all of those things, impulses, fall under executive actions. Our affective symptoms, so affect is our facial expression, but in this sense, it means our mood. So it could be an unstable mood. It's erratic, they're labile, changing easily, incongruent, not what you would expect. Are they depressed? Are they super happy, like weirdly unhappy? This further impairs functioning. It increases their suicide risk. Just because they're all over the place. Self-assessment is hard to work with these patients, and in part it's hard because of something called anosognosia. They cannot realize that they are ill. Anosognosia is basically a word that means they have no ability to understand that they are ill. They may not participate in treatment because there's nothing wrong with me. And it's not that they're in denial, it is this anosognosia. When we combine this, especially with paranoia, it makes it very hard because they are not going to seek out help. Self-assessment, we may be anxious or fearful working with these patients, especially if they're paranoid and scared of us. We may be frustrated because they're a frequent flyer and they keep coming back and they just don't want help. We have to make sure we're talking about it with someone, make sure we're understanding what is going on with them. We have to avoid that countertransference. So what are we doing when we assess these patients? We have to assess for medical problems. We can see some medical problems mimic psychosis. So we do just have to make sure we know what's going on. Drug and alcohol use. Drug use and alcohol use can contribute to hallucinations. We can see, especially alcohol withdrawal, we can see hallucinations come into play with methamphetamine use, with our psychedelics, PCP, magic mushrooms, ketamine, all of it. We have to do a full mental status exam, make sure we know what's going on. And we have to do that cognitive assessment, that reality testing. Are they having hallucinations? Can they understand where they are and what's going on? Have to assess for hallucinations. And when we're assessing for hallucinations, a priority patient, active hallucinations. Kind of like if we have a list of patients we're going to choose from, I'm always going to go to the actively suicidal with a plan patient. My next up, or if maybe I don't have an actively suicidal patient, a patient with active hallucinations, because I need to know what's going on with them. Hallucinations can be dangerous. They can be scary for our patients. So we have to make sure we're assessing for that. What are the voices saying? Get those command hallucinations in. We also have to assess for delusions and suicide. Can they take care of themselves? Can they get their meds? Can they go to the doctor? How much is this impacting their function? How well is their family doing this? Because their family is also often not doing well. I'll post a video to a very short documentary. I don't think we'll have time to get to it in class about what it's like to have schizophrenia, what it's like to have a family member, and it's not easy. Potential nursing diagnoses are going to depend on if we're looking at that negative or positive symptoms. So remember, our positive symptoms are psychotic symptoms. So psychotic symptoms, delusions, hallucinations, disorganized thought, hallucinations. Yeah. Negative symptoms are all of our A words. So social isolation, low self-esteem. What do we want for our patients when we look at our outcome identifications? Going to depend on what phase. In our acute phase, we just want them to be stabilized. We are trying to get them stabilized. In phase 2, we got that stabilization. We want them to understand what's going on. We want to get the medications under control. We want to deal with symptoms. In the acute phase, we definitely need that 24-hour support. Stabilization and maintenance, we don't. Maintenance, we want to maintain everything that we've achieved, kind of just what it sounds like. We want them to have some type of quality of life. We want them to maybe be independent if they can. Make sure they take their meds, have those trusted relationships, especially in that maintenance phase. Community-based services are very helpful. So in our planning, we've kind of just said all of this. Maintenance, we're going to do patient and family education, and relapse prevention is the big one. Stay away from drugs, take your medications, be alert to changes that are going on. Implementation, do a full eval, right? Get the medications, get them into support groups. Support supervision in the milieu is extremely important. Monitor fluid intake. A lot of them tend to have that polydipsia where they are drinking more. I hit a button. We also just want to make sure that they're drinking. Working with aggression. Honestly, y'all, we just had a whole week of lecture on this in Unit 8. So we have to assess the risk. We have to take safety measures. Regardless of what's going on with our patient, the things we're going to do for aggression will always be the same. Interventions, give their meds, trusted community, teamwork, safety. We do want to get this patient to activities and group therapy as much as we can. It is good for them to be able to be with other people. Counseling techniques, if we are some different things to think about working with hallucinations and delusions. You can't always, especially in the beginning, that acute phase where we will tend to see them. If we are talking about our acute psychiatric facility, we can't always be like, well, that's a hallucination, you're making it up. If your patient is like, there's spiders crawling on the wall, they truly are seeing spiders crawling all over the room, and it's going to be scary for them. We have to acknowledge those feelings, because challenging them and saying those spiders aren't real is not going to help, because they are real to them. So it gets us into this gray area. Do we talk about the hallucinations or do we not? We do have to acknowledge, I don't see spiders, but I do understand that you see spiders, and it is very scary for you. Delusions are a little bit more complicated, especially if we're talking about our paranoia. The CIA is out to get me. The CIA is not out to get you. No one is going to hurt you. Well, you're just saying that because you're working for them. So if we challenge delusions, it does, especially in that paranoia, they kind of turn on us. So you have to walk this fine line. Associative looseness is one of those where they're kind of talking all over the place. It falls in line with our flight of ideas type stuff. Health teaching and health promotion, honestly, all it's going to be the stuff we've talked about. Take your meds, go to the doctor, don't drink caffeine, don't do drugs, make sure you're getting sleep, make sure you're getting regular exercise, all of that basic stuff. Psychobiological interventions. We do have a few different types of meds. First, second, and third generation. For the most part, third generation antipsychotics get grouped into second generation. We do have short and long acting injectable antipsychotics. Short acting is going to work in that moment. I'm going to give you Haldol when you're paranoid. I'm going to give you that moment. It's going to work, and that's the end of it. A long acting injectable is going to work for 3 to 4 weeks. So long-acting injectable antipsychotics are nice, and we have a bunch of different types of them because I can give it to the patient on March 1st, and they go back to the doctor on April 1st. They can go a few weeks. They don't have to take a daily pill. But long-acting injectables are also hard because the patient may not want to go back to the doctor as frequently. So when we look at our first-generation antipsychotics, we look at dopamine dysregulation as a cause of schizophrenia. So these are dopamine antagonists. They block dopamine receptors in the motor areas. However, dopamine is also associated with fine motor. So when we block this dopamine, it has major side effects and does something called extrapyramidal symptoms. And these are movement side effects. First generation antipsychotics, because they just block dopamine, they tend to just affect the positive symptoms. So I am saying this again, our positive symptoms are our psychotic symptoms. Delusions, hallucinations, disorganized thought, disorganized speech, disorganized movement. All the things we add to someone who normally does not have schizophrenia. We do have a lot of disadvantages to our first generation antipsychotics. We'll go through what these are, and actually this is where I'm going to pause and I'm going to switch to a different PowerPoint to review some of these things for y'all. So give me a second, and when I come back, y'all will see a different PowerPoint here. Okay, so we have switched gears. This is that separate PowerPoint that I've done on our antipsychotics. So like we said, we have 2 different types of antipsychotics, but we have some different names for those classes. This here says conventional. They could also be called typical or first generation. So 3 names that basically mean the same thing. Atypical are our second generation. You can see I do not have our third generation on here. This first one right here, aripiprazole, which is Abilify, is our third generation. Third generation just has less side effects. We do historically tend to group it with our second generation. Chlorpromazine, isothiazine, flufenazine, haloperidol are some of our most common first generation antipsychotics that we're going to see. Our zines, except for Haldol. So Doan, we can see Doan and Dean and Peens with the different names of them. I know it's hard, y'all. We just got to be able to recognize some of these. Most of the time, if we can put it in a class, so if we see flufenazine, we just need to know flufenazine is a conventional, typical first generation. Chlorpromazine, isothiazine, conventional first generation, typical. Same thing if we see clozapine or quetiapine. So this is again like everything I've said before. Our first generation works with dopamine. We tend to believe schizophrenia is caused by dopaminergic overactivity in that mesolimbic system. So it works to kind of antagonize the dopamine. It blocks the dopamine receptors. It helps with the positive symptoms, hallucinations, delusions, strange movement. However, because we do that, we cause all of these side effects. We can see it worsens cognitive and negative symptoms, which is why we don't use first generation as our first line, because it makes our cognitive and negative symptoms worse. We always, generally, we've talked about patient education, have to be open talking to them about side effects because there are a lot. These are definitely meds. We have to look at our side effects, and we have to look at our abnormal involuntary movement scale. We'll go over that in class, just how we tell how bad our patient is moving. So when we look at these things, we have again our normal and then our not so normal side effects. These are anticholinergic, constipation, dry mouth, congestion, blurred vision, dry eyes, photophobia, hypotension, tachycardia, urinary retention, hesitation, sedation, weight gain, are kind of those things we expect to happen. But our not so normal side effects are big ones, right? EPS are those weird movements, increase in prolactin. We'll go through more in detail EPS, neuroleptic malignant, metabolic syndrome, agranulocytosis, anticholinergic toxicity. So we have a lot of not so normal side effects we need to know. This is kind of just a brief overview. It is not from your textbook. It's from a different textbook we use, but it kind of defines them very simply. Akathisia, we'll watch all these videos in class, so I'm not going to go through this now. It's actually from the Greek akathesis, which means no sitting. And that's exactly what it is. This is a person with inner restlessness. They cannot sit still. Oftentimes, if we have a patient who's anxious, we give them Haldol. All of a sudden, they appear more anxious, and we're like, well, the Haldol didn't work. Let's give them more Haldol. So really, with this one, we just have to recognize that it's a side effect and then let them pace. Don't give them more Haldol. Pseudo-Parkinsonism. Oh, I clicked it too much. I don't want to start that now. Okay. Pseudo-Parkinsonism is just what it sounds like. Sometimes it's called drug-induced Parkinson's. It has to do with the fact that we're messing with that dopamine. It's temporary, stooped posture, they're rigid, they have slow movements, the shuffling gait, pill rolling, they're rolling their thumb and their fingers like they have pills between it. We want to stop the medication and or start Cogentin. This oftentimes, if we go back in history, was called like the Thorazine shuffle. Our next one is something called acute dystonia, and this is essentially acute. It comes on suddenly, and it's a spasm. The muscle has spasms. Your patient, like this guy, is essentially going to be stuck like this. He will not be able to move his head or his arms. The muscles have contracted and gotten him there. It's not dangerous, but it's scary and uncomfortable. If breathing is impacted, we have these laryngeal spasms. If they are occurring, if breathing is impacted, that's the really only emergent time. Sometimes this has an oculogyrate crisis, and that basically means our eye muscles are contracting and it's fixing our eyes at the ceiling. This patient, we want to give IM Benadryl and IM Cogentin. We don't talk a lot about Cogentin in here because it's a Parkinson's med, because it has to do with dopamine regulation. So we're basically treating a lot of these by fixing the dopamine dysregulation that our meds have caused. Tardive dyskinesia can be particularly disfiguring and incapacitating. It is a long-term side effect. 25% of patients will have this with prolonged treatment. So these patients have been on these first-generation meds for a long time. They're weird movements, involuntary, repetitive, chewing, sticking out the tongue, sucking, smacking lips. Even if we stop it, so if we have a patient who's on long-term Thorazine and they wind up with tardive dyskinesia symptoms, we discontinue the Thorazine, the symptoms are not necessarily going to go away. The Parkinson's symptoms, pseudo-Parkinson, may go away. Acute dystonia will go away. Tardive dyskinesia will not go away. We do have two meds, and these are newer meds, Ingrezza and Austedo, and like I said, I hate how these names, I never know how to pronounce them. They haven't been around that long. They did not exist when I first started nursing. So in the last decade or so, they've really come out for the treatment of tardive dyskinesia. So we just have to be mindful. I always like to tell y'all, we do see this with other medications. A lot of our GI meds for nausea and reflux can cause this. Reglan, I can never say it, but some of those other meds. So just good to be out on the alert that it does happen. Neuroleptic malignant syndrome is one that is good to know because it's deadly. It could very well kill your patients. It is an autonomic dysfunction caused by hypertension, tachycardia, diaphoresis, incontinence. It does not necessarily cause, like in some of the toxicities we saw that like hyperreflexes and stuff, we don't see them. This is a patient who's going to present all of a sudden with a very high fever, high respirations, altered mental status, muscle rigidity, along with that hypertension, tachycardia, diaphoresis, incontinence. It comes on suddenly. We do tend to see this more in our first generation. It has to do because of dopamine regulation. It is a 911-able. Without treatment, 6% of patients with this are going to die. We do see other types of complications: organ failure, sepsis, kidney injury, rhabdomyolysis. This is very much a stop the med, give them fluids, manage their temperature, watch for complications. Just be alert for that sudden, and when it says excessive fever, high fever, we're talking like 107. This is not like 101. It is a high fever out of nowhere. Combined with hypertension, tachycardia, sweating, incontinence is what we see. So now we're switching to those second generation atypical antipsychotics. These affect dopamine, but they also affect serotonin. Our first generation just did dopamine. These are doing dopamine and serotonin, so they're affecting our positive and negative symptoms. So we use these more. However, we again see EPS. We are going to see anticholinergic toxicity. We'll go into that more specifically, but we also now see metabolic syndrome. Patient education is the same. These are Geodon, Haldol, not Haldol, y'all forgive me, Geodon, Zyprexa, Latuda, Abilify is that third generation that gets grouped into it. We have a bunch. So we have a minor risk, minor of all of those things we talked about with first generation. It can happen, but it's not as likely because we're not just affecting dopamine, so we're not seeing that much dopamine dysfunction. However, when we throw in the serotonin, especially, these patients are at a high risk of metabolic syndrome. Weight gain, dyslipidemia, increased blood glucose, insulin resistance. This is going to increase your patient's risk of developing hypertension, cancer, diabetes, cardiovascular disease. Especially in our modern population who is already at risk for these things, it makes it not any better. Agranulocytosis. This is possible with all antipsychotics, and I stress that because I've seen it in questions with all antipsychotics. However, it is also, and I've seen this in questions, specific to clozaril or clozapine. There is a black box warning for clozaril or clozapine. Your patients have to go to a special doctor. They have to go to a special pharmacy. They get like weekly blood draws because it causes agranulocytosis. A means without. Granulocytes are a type of white blood cell, so it causes neutropenia. Your patient cannot fight an infection. It leads to death. So we have to be careful. If we have a patient on clozapine, we have to monitor those white blood cells. We have to provide patient education if you start to feel sick. You have to hold your med. You have to call the doctor. Get that CBC. We have to look for those signs and symptoms of infection. Where in that neuroleptic malignant syndrome, it talks about that super high fever, hypertension, tachycardia, sweating, incontinence. This is usually agranulocytosis. Your patient's tired. They're having a little bit of increased respirations. They have a 101-degree fever and they're complaining of a sore throat. We have to do that lab draws. We have to monitor that white blood cell count with this medication. And that is that whole black box warning. This is a great med. We just don't use it frequently because of that risk and how dangerous it is. So one of the last things we're going to talk about is anticholinergic toxicity. We know our anticholinergic side effects: can't see, can't pee, can't spit, can't poop. So we have those. However, when they get worse, we get this autonomic nervous system instability. We get delirium. We get altered mental status. Fever. It's not just hesitancy with urination. Now we cannot urinate. One of the things we often see in psych, we see these mental status changes. Your patient's been psychotic. We've had them on this med. They're doing okay. And then all of a sudden we see a worsening of psychotic symptoms, along with worsening of hallucinations, worsening of agitation, combining with all of these things. That mental status change is a good indicator for anticholinergic toxicity when we look at our nursing implications. Anytime we see psychotic symptoms getting worse, look for anticholinergic toxicity. Hold med, call the doctor, especially anytime with fever, right? Cooling measures, give that cooling blanket. If they can't pee, give a urinary catheter. Seizure risk, benzos, some type of sedatives. I cannot say this, physostigmine is the med to reverse anticholinergic toxicity. I'm going to pause so we can switch back to that other PowerPoint. I'm going to pick up on this side. We've talked about anticholinergic toxicity, NMS, and agranulocytosis. We can see prolongation of the QT interval. That is in an EKG. So we should do an EKG before we start the medication. They can cause liver impairment. So we just need to make sure we're drawing our liver labs and just making sure their liver is okay before we keep giving this med. If we're talking about our advanced practice providers, therapy. We tend to forget that these patients don't need therapy, but they do. Teaching, medication, prescription health assessments, working through their cognitive structure, and family therapy is a big one. This is hard on the family. Evaluation, we have to keep evaluating. We have to adjust meds as needed. New meds are coming out all the time for schizophrenia. Half the meds we're talking about when we look at their names, especially the second generation, they're super new. Even if the patient looks like they're okay outside, symptoms tend to be still going on inside. Small goals. We've talked about that a lot. This is not I'm going to give you this med, you'll be better in 2 or 3 days. And we have to show them more caring. We have to be nice. Quality improvement, we always got to be evidence-based. We got to look at what's going on and just kind of incorporate all those new things into treatment. A lot of the things I'm teaching you are not what I was taught. 17, 18 years ago when I was taking this class, and even my first few years on a psych unit, we did not do these things. It was not good. So we have to make sure we're staying up to those latest standards of care, and we're doing the most evidence-based practice. I'm going to go pause now because the next thing we got, which I'm going to do separately, is chapter 24, personality disorders. It is a lot. I know. We're going to get through this. If y'all have any questions, let me know.